Trigger warning.
Okay, guys, we left with depression. We went over this list. Any thoughts, questions with this? Any thoughts, questions? Any wild points from last time? Anything? No, forget it. All right. Anybody else?
Like, okay.
Yes.
Just that your two biggest indicators of like organic depression were anhedonia and psychomotor retardation.
Right. And the idea with that, remember, depression, I mean, all these, any of these could represent both, because a person can look completely clinically depressed and not have the disease of depression. You see what I'm saying with that? But anhedonia, psychomotor retardation, remember, pardon me, the real issue of depression is not so much the feeling sad as it is a body energy utilization issue. And it takes energy to feel good. It takes energy to be interested. It takes energy to care about something, to want to do something. Those kinds of things like that. And when you see, and we're going to see today, you're going to see this psychomotor retardation. It just takes so much energy just to think, to just deliver the answer, to talk, to that kind of a thing like that. That psychomotor retardation. Now this says physical sluggishness. Actually, no, it's mental sluggishness. It's like this person is mentally, they've got lead boots on, trying to walk uphill in syrup. If you see what I'm saying with that, mentally, that kind of a thing like that. That combined with then anhedonia. That's a really important rule-out thing. If you're talking to somebody of functional depression, if you hit the right topic, if you say something the right way, you'll see a gleam of interest. You'll see a gleam of, yeah, that could be, or something like that. You see what I'm saying? Mm-hmm. You'll listen for future orientation kinds of things. You know, if this could happen, that would, those kinds of things like that. But with anhedonia, no, it's just, there's nothing good about anything in the future, anything like that. Does that make sense? Along with this physiological inability to feel good. That person can't just choose to get up in the morning and have a good day any more than Christopher Reeves could have decided to get out of the wheelchair and run a mile. Physiologically, they're incapable of that right now. Does that make sense? And so, yeah, those are two big markers with that. Any other questions with that, with this stuff, this list? We left with it, and I wanted to talk a little bit more about this, and we got another little wrench to throw into this. Again, recurrent thoughts of death, suicide, with or without a specific plan. And gang, yeah, this is a vital part. We're going to be talking about duty to warn stuff and things like that down the line. But this idea that listening for, and again, if you're hearing future orientation stuff with your client or not, or things like that. Now, when we talk about suicide, and gang, remember, this one gets a little bit tricky because at some point you get tired. And maybe have you ever experienced it? Oh, if this don't happen, I'm going to kill myself. If you don't love me, I'm going to kill myself. Oh, I'm so tired of this, I'm going to kill myself. And at some point you get tired of that, then you say, well, you know what, just go ahead and do it then. And something like that. Had a counselor one time said, I'll get you the day I'm good. And that was that counselor's last day in my program, by the way. Never, never, never. If you're hearing ideation of this, thoughts of this, threats of this, never, never, never. I don't care. Yeah, you know, the distinct possibility is this person is manipulating. You know what I'm saying? Probably. There's a good chance they're manipulating. But you never, never, don't you ever feed into that? Don't you ever start to play with that kind of a thing? You take every ideation, every threat, you take every one of those things very, very serious. And you check it out, kind of a thing like that. You see what I'm saying? Many suicides are accidents. You know, I mean, it's kind of like, I really didn't want to kill myself. I wanted you to walk into the bathroom while I was standing on the edge of the tub with the rope around my neck, and I accidentally slipped off the edge of the tub. I didn't really want to kill myself. I wanted you to walk into the bedroom and see me passed out with a pile of pills laying around on the bed. But I took a few too many, got disoriented, took too many. And now, those kinds of things like that. You see what I'm saying with this stuff, you guys? And if you push somebody with that, because if their manipulation stops working, number one, it's going to escalate. Does that make sense? Oh, listen, I'm going to have to get a little bit more serious about this. And then that person starts to they start to do things that become more and more dangerous anyway. And yes, it was just manipulation. Well, I don't want to feed into that manipulation. That's not cool. And you're right, that's too bad. You're feeding into that manipulation. But I'll tell you what, you guys, if I'm confronted with that and I'm going to make a mistake, if I'm going to make a mistake here, I can fix manipulation. If I end up getting manipulated by this person, I can fix that. I can't fix dead. Does that make sense? Take every one of these very, very serious. And then, of course, what do? We've got our little thing. Hey, are they talking about it? And then, what's the next step with that? What's the next step? Do they have a means? And then a plan, excuse me. And then do they have a means to carry out that plan? You're absolutely right. That kind of stuff like that. Look at past. Look at past history. Have they tried before? And if they have tried before, how lethal was that attempt? I mean, think about this. Taking 20 baby aspirin, calling 30 people and telling them about it is different from shooting themselves in the head or something like that. You see what I'm saying with this kind of stuff? And usually, guys, my experience, and like I say, I've been doing this for a few weeks now, and my experience is I have never met somebody who wants to be dead. I have met people, and I've worked with people who they have gotten to the point in their life where they just they believe they have no other options to make the pain go away. Does that make sense? They have no other option. It's not that they want to be dead. They want the pain to be gone. And they get to a point where they can see no other option. The only way to make the pain stop is to kill themselves or something like that. Does that make sense? Now, we're not talking about, that bunch of nuts that decided when the comet's going to come by and they got to kill themselves so they can jump on the comet and go for a ride to Disney World or something like that. You see what I'm saying? Remember that? Mm-hmm. Does everybody remember that? What was that nut? That guy? What was his name? I forgot.
Oh, it was Haley's Comet, wasn't it?
Well, yeah, but what was it? The leader of that bunch and so I can't remember there. But remember that? And now that's different. They wanted to be dead because they believed that being dead that way was going to get them to someplace better. But in a way, if you think about it, they must have been suffering something that they wanted to get away from, which made whatever better is going to be look so attractive in the first place. Does that make sense? And so basically, gang, you work with a person, and when you talk to the person about this stuff, don't pussyfoot around. Well, do you think that maybe, have you ever wondered if maybe what it would be like if you weren't here? No, don't talk like that. Have you thought about suicide? You see what I'm saying? Be very straightforward with that. So, well, yeah, but what if I put the idea in their head? No, you're not going to put the idea in their head. All right? You have to assess this. You have to assess this. And then, of course, the other thing is dangerousness. And again, that's going to be one of these things, the dangerousness. Here the client is in the middle of a pretty intense session. And all of a sudden, and they're really upset about this and that. And I had to just fucking kill that bitch. What does that mean? Check it out. Check it out. Be very direct with that kind of stuff. You see what I'm saying? Now we're going to talk, again, when we get into assessment, the whole idea of a duty to warn. We've mentioned it a little bit already, but you guys are going to be, and once you start your internship, you'll become mandated reporters. Does anybody know what that means? Yes.
You're legally obligated to inform certain people about abuse or dangerous situations.
Yes. And you have to do that. That's not a choice you have. That's the law. And if you don't report, and it can be shown that you knew enough and you didn't report, you're liable for that. Does that make sense? So you're mandated reporters. And once you start your internship, you're mandated reporters. And so we're going to talk more about that and the Tarasoff case and make sure we're clear with all that stuff. But the fact is that, with any of these disorders or anything, suicide, dangerousness can be an issue. But yes, it is. It's pretty much, there's a big correlation between again, depression and some of that kind of dangerous behavior stuff. And so, you know, don't pussyfoot around with it. Don't try and avoid it or something. Be very just straightforward with this and talk about that. And then about this more with assessment, that there is a danger here. You have responsibility to take certain action. Does that make sense? And break confidentiality. That kind of a thing like that. So, this depression thing. And again, these things, just like with the schizophrenia spectrum we talked about, there could be lots of reasons for any of these things. In this case, it has nothing to do with depression. Or, don't forget, and then the complicated thing, is it organic or is it functional? Is it reactive? Is this complicated bereavement? Is it this? Is it that? And we gave examples of looking at that kind of thing last time. The car crash lady and things like that. And so, it's difficult. This one, schizophrenia is pretty straightforward. You know what I'm saying? I mean, we're seeing hallucinations, we're seeing this and that and everything else. Always be careful. Like we said, even with those schizophrenia symptoms last time, there could be lots and lots, many reasons for any of those symptoms that have nothing to do with schizophrenia, but a hallucination is a hallucination. You know what I'm saying with that? With this gets really tricky. And so you've got to know what you're working with. And again, gang, I hope last time I illustrated how important it is. And your responsibility to understand this stuff and tread this very carefully. When you're, especially in the beginning, as you're a beginning counselor and starting to work with this kind of stuff, who is going to be your very best friend as you're negotiating this stuff and trying to figure out what's going on with that client? Who's going to be your very best friend? And don't be embarrassed or hesitate to use that person. Your clinical supervisor. You see what I'm saying? Especially when, in the beginning, you know, this is a curve. This is a learning curve. And you're going to be confronted with this stuff. I mean, depression, anxiety, those kinds of things. You know, that's a major part of the whole experience with substance use, you know. And some people, hey, is the person using drugs right now because they're treating their depression? Or are they depressed right now because their life is such a mess because they're using drugs? Is there a combination of both? Is it this? Is it that? Understanding and putting together what's going on with this individual. And, you know, well, guess what? We got another dimension. Take a look at this. Now, don't forget. Hey, what is mood? Somebody, quick quiz. What's mood?
Client's report of emotional state.
Client's self-report, how they feel. What is affect?
How other people report it.
How other people see it. And then we talked about mood, affect, and congruence. I'm happy, cry. I'm fine. I'm feeling. Or how about this one? I'm sad, laugh. Those kinds of things like that. And so, paying attention to that kind of stuff. Hey, another thing with this, big, just like with the personality disorders. State trait. What is state? What is state? What is state? The situation as it is. And don't forget, you guys, we can all look and be pretty crazy under the right circumstances. Does that mean we have a disorder? It's got to be trait. In other words, this is how this person would be being, no matter what. Under what circumstances, with who, for whatever. You see what I'm saying? That trait thing. Be very careful with that, guys. Again, as we harped about last time, that proverbial permanent file. That proverbial permanent file. Be very careful. And with depression, state can be a big deal. I mean, think about that. That person walks in. That person walks in, and they're just mad, sad, hopeless, helpless. And guys, don't forget, stress. Anxiety. And how that brain reacts to that is a very expensive thing anyway. This person's tired. They don't feel like getting fucking out. They don't this, they don't that. And here they are sitting for their first appointment with you, the intake screener for the ABC treatment center. And they're looking at all these things. Is that because they have depression, or is that because their life is one hell of a train wreck right now? And that's just how they are right now. You see what I'm saying with that? Don't just be right away. You see that label maker kind of a thing. that person? Are they in a state of affairs right now called they're just trying to walk out of the middle of this addiction and this mess their life is? That kind of a thing. See what I'm saying? Yes.
What if their state end up turning into a trait?
Well, that means it was trait in the first place.
I mean, like if I'm just in a real messed up mood today, in the environment that I'm in, it's not like I want to be in that mood, but if I have to go out the door, they're going to expect for me to be the same way I was yesterday, so I have to put on this mask.
Well,
or
you got to, in other words, if you're, that's another thing, is this person playing this?
They don't want to be.
That would be functional stuff. And then that would probably be those states. You're reacting to a state of affairs called demand characteristics right now. That kind of thing. Does that make sense? And yeah. So, but if what you think is state, but then it does continue with that. And pay attention to that issue right there, those demand characteristics. Is there a reason why this person is still getting paid off for acting, being this way? Or what? But no, there's not at this point. Well, then you know what? It wasn't state anyway. It was trait.
It was trait. Yeah.
And that's the thing, you guys. Something that's in the beginning, you got to step beyond just that right now for trait. You do have to see. This is where history is real important. And what were they like before that? What was this? What was that? You see what I'm saying? Hey, with depression, another big thing is getting history of family. Depression does run in family. In other words, there's some pretty distinct kinds of evidence for depression running in families and things like that. Are there other family members who are suffering this? Are there other family members who are being treated for depression or things like that? All those kinds of things. And then, this is not easy. Again, that is, said, fine line kind of a thing. And it's your responsibility to understand all this stuff and tread that pathway very carefully when you're about to say, do, write, label make this stuff. Does this make sense? Major depression. The person has the disease of, and I call unipolar. In other words, one way, always major depression. Do you see what I'm saying? That's one depression. That's going to need a specific kind of an intervention. And again, probably one of the meds that aren't even close yet to what we really need them to be for the welfare of that patient, but they're the best we've got. And then we have this person who is down there, major depression, but then all of a sudden they go up. And again, here's our normal range right here. And again, people have gooder days, badder days. And don't tell your English teacher how I talk. That kind of a thing like that. And stuff, look at a range of normal. But this person, they start to go up. They don't just get to normal, they go above, way sometimes above normal. And again, that person, from the depths of that depression to this sudden burst of energy, this sudden burst of exhilaration, of excitement. This person, all of a sudden, think about this, from the depths of that depression, going up, feeling so good for that individual, it seems like. And this is what? Bipolar 1, what did we used to call that?
Manic depressive?
Manic depression. And the idea that this person now has gone manic. And again, wild flights of ideas. Wild, impulsive kinds of behaviors. Hypersexuality, hyper drug use, hyper this, hyper that. Spending. This person investing thousands of dollars they don't even have really, or things like that. I don't know if I told you, as I produce rock concerts, and one time we were having a pretty heavy duty production meeting, putting together some ideas and so looking at some sound people and some stage people and stuff like that, and this guy right in the middle of the meeting goes manic, and he just frenetically, the president calling, what are you doing? This guy became possessed of this idea that he's going to call. He's calling London, England. He's dialing numbers all over the place. He is possessed. His what? Belief. He's going to get a hold of Mick Jagger. And he's going to convince the Rolling Stones to come to Peoria and play a concert for us for nothing. Just let me do this, man. Let me do this. I can do this. You see what I'm saying? And try and stop it. No, I'm going to do this. I can do this. You see what I'm saying? I mean, just a wild place like that. We can see delusions of grandeur with this. Again, this person, they get on that proverbial Napoleon complex, that God complex, or something like that. They're on a mission. They're just going. And like I say, hypersexuality, drug use, everything is just escalated, elevated, wild behavior with that stuff. You see what I'm saying with this? In this building one time, and I'm walking around, and there was a guy, and when he would go up, he would have a watch thing, and he would just grab people, say, grab their wrist, look at that, he put their watch up there. I know all about these watches. I invented the watch. I can tell. Is it broke? I can tell you everything about this watch. Rip that watches off. See what I'm saying with that? And then, of course, then back down. Manic depression. Now, the basic meds for this, what are the basic meds down here?
Antidepressants.
The SRIs, the NRIs, the MAOs. It's those meds that somehow, and we're going to see this next semester when we get in the brain. You've heard of the SSRIs, right? What is that? Selective serotonin reuptake inhibitors. We're going to see how that works next semester in the brain. SSRI, they create that chemical situation in the brain where more serotonin becomes available. Before the SSRIs, we had the NRIs. And Elavil, dizipamine. Anybody ever heard of Elavil? Dizipamine, some of those kinds of meds. Now, they were NRIs. They, instead of serotonin, they would make more norepinephrine available in the brain. Before we had NRIs, we had the monoamine oxidase inhibitors. And we're going to see what all this stuff, you guys, we're going to get well into the neuropharmacology of this stuff. And the monoamine oxidase inhibitors, monoamine oxidase is an enzyme that breaks down serotonin and norepinephrine. And so if you would take a monoamine oxidase inhibitor, it would inhibit that enzyme, which meant that the serotonin, the norepinephrine, wasn't being broken down so much, which meant there was more serotonin, norepinephrine available at the synapse, and for some people, they started feeling better. Problem with the monoamine oxidase inhibitors is what? Well, they got all kinds of side effects. You start jacking with the enzyme system, you're messing with every damn cell and system in that body. And they had some pretty serious side effects and sometimes some dangerous side effects, sometimes lethal side effects, those kinds of things. They still to this day. I mean, go to the pharmacy and just off the shelf and start to read just about anything you read. And, you know, has anybody ever read the tiny print? The precautions. And I'll bet you still, it'll be on that someplace, do not take this med if you have in the last 60 days or are now taking monoamine oxidase inhibitor meds. You see what I'm saying? Because there's probably going to be a dangerous interaction there. You start jacking with the enzyme system. So, while monoamine oxidase inhibitors were the first antidepressant drug, they had some problems. And so then we discovered Elavil, dizipamine, the norepinephrine, and again, and with them, when norepinephrine gets shot out into that synapse, well, they get sucked back in, the reuptake pump. Those NRIs, they plugged up the pump so that it couldn't suck back into norepinephrine. Meant more norepinephrine out there for some people, which was great for some people. That helped them with their depression. And we're going to see all that once again. And what is norepinephrine, what is serotonin, and things like that. And that helped some people, but not everybody. And besides that, it had some side effects. Norepinephrine is a major excitatory stimulator kind of a thing. As a matter of fact, the stimulant drugs work by what? Jacking out norepinephrine. When you get under fight or flight, And you get all that sudden energy and stuff. What is that? Norepinephrine. And so if you're taking a med now to keep more norepinephrine out there longer, what do you have? You're jittery, you're all that, sleeplessness, jittery, and on edge, and that kind of a thing. You see what I'm saying? So it had some side effects. And it didn't help everybody. So then we discovered, who's old enough to remember the day Time magazine introduced us to Prozac? I mean, and Prozac was lauded as the magic cure. Prozac was going to be the happy pill of the human experience. It was instead of a norepinephrine reuptake inhibitor, it's a serotonin reuptake inhibitor. And it was called an SSRI, a selective serotonin reuptake inhibitor. And that meant that it was supposedly just going to affect serotonin in the mood parts of the brain, not the other where serotonin does stuff. That turned out not to be the case. There's no such thing as a selective. We don't have smart drugs like that yet. You see what I'm saying? Yeah, serotonin, dopamine, there are different kinds of serotonin. There are different kinds of dopamine and things like that. They do different jobs and stuff. But these drugs weren't selective after all. And guess what? They also did not help everybody. And the other problem was that they also had side effects. And serotonin plays a major role in things. Hey, the NRIs, one of the biggest problems with the NRIs, yeah, jittery and that kind of stuff. Another major problem with the NRIs is norepinephrine plays a major role in the satiation centers of the brain. That brain that tells us when we wake up, you're hungry, go find food. We find that food, we start eating. There's another part in that brain that says, good, you found food, you're eating food, but now you've had enough. Stop it, you're not eating food. Well, norepinephrine plays a role in it.
Mine's broken.
You jack up the satiation center. The next thing you don't know when you don't need no more food. And one of the biggest problems people had with the NRIs is they started gaining weight. That kind of a thing. You see what I'm saying? The SRIs. Serotonin plays a major role in the mesolimbic system, part of the motivational system, that plays a role in what makes us want to do things, including sexuality. And when you start to jack with the serotonin, it jacks with that system, and the next thing you know, well, what was that? Well, people, those sexual side effects and things like that. Another problem with that serotonin reuptake inhibitor, serotonin is a balancer throughout the entire system. It balances how other drug or other neurotransmitters are doing their very finely tuned job. And you jack with that, and pretty soon, what did we start to hear about? That people on Prozac were committing suicide. Which was, for Christ's sake, I thought we were taking this so that we weren't depressed, and now they're committing suicide. And it was jacking with that very fine system there. There's another thing with this, you guys. Besides that, what's another reason why antidepressant meds in general can sometimes result in a threat for suicide? What's another reason?
I was always told that you get this initial spike in energy, but you still have all that bullshit in your head. And so now you've got the energy to kill yourself.
There you go. You're yes, exactly. And the thing is this. I mean, at the depth of that depression, you don't even have the energy to do that, to kill yourself. But once you start feeling better, and that now you've got the energy to carry out the suicide attempts in the first place. Exactly what that is. Does that make sense, you guys? And so you're also, like I said, you're paying attention to this, you're assessing this stuff. But that's the drugs down here. This person would probably be on those meds, but then they're also going to be on a mood stabilizer. And still, the gold standard mood stabilizer is what? Lithium. Lithium. It's still the gold standard. The problem is lithium is a dangerous danger. We all have lithium in us. And we're not quite sure what the hell lithium is for yet. But for some reason, somebody way up like that, and all this wild stuff, lithium calms that and brings it back down to it, stabilizes that mood. The problem is, you need this much lithium to get better, this much lithium, and you're dead. You see what I'm saying? And so, on lithium, that person is going to constantly be getting blood levels checked and all these kinds of things like that. And lithium toxicity and how dangerous that is. And so what did they look for? Well, then are there alternatives? Depakote and some of those other neurological, Neurontin, some of those kinds of things like that. And they also have mood stabilizer properties, but not as much as lithium. And so with bipolar 1, still the gold standard is lithium. Does that make sense? However, and gang, what do we used to call this? Manic depression. Why did we change that? Why did we change that name? Because we have this right here. Look at this person. They're also, if you take this person, they never even get to normal. They look on the surface always depressed. They don't go high, they don't get to normal, let alone above normal. They look always depressed. But look at this person. They are also what? Cycling. They're also cycling. Now this person, back in the old days, they never got to normal, let alone high. They was always depressed, and so what did they get? Antidepressant meds. And they weren't being nearly as benefited from that as other patients. And then you have to look at this. This person's cycling also. This person could probably also use what? A mood stabilizer. Why weren't they getting mood stabilizers? Because they weren't going manic. You see what I'm saying? They're depressed. They're always depressed. Why weren't they getting mood stabilizers? Because they weren't going manic. So, okay, then what do we need to do? We need to change the verbiage from manic depression to bipolar. Does that make sense? Because that way I can recognize, you know what? I know you're never really up, but you're also cycling you. Now we can recognize this person may need a mood stabilizer also. Does that make sense? This is the person who, some of those lesser dangerous, Depakote, some of those kinds of things like that, would benefit hopefully from that. Would benefit from that. Does that make sense? Yes.
Would that take them to normal, though?
Pardon me?
Would they ever go to normal on medications?
Sometimes. I mean, we could, they maybe flirt at the doorstep of and play, but there's still is that.
Okay.
Does that make sense?
So would that just present like your depression comes and goes?
This is where not so much comes and goes, but gets better and worse. Sometimes just very, very depressed, and sometimes still depressed, but not quite as depressed. And then the next thing you know, back to very depressed, and then not quite so depressed.
But then you're not quite so depressed could feel like normal if you're used to living in...
Exactly. Yeah. And again, you have to... Gang, this gets pretty complicated, doesn't it? This gets pretty complicated. You guys have this responsibility. You got to understand this. You got to understand this. And yes, this can flirt with normal a little bit, but they don't do this. But they still are cycling. And that's why we changed the name from manic depression to bipolar, so that we could distinguish, yes, bipolar 1, bipolar 2. Does that make sense? And that way it lets us recognize bipolar 2 could probably also. Bipolar 2 isn't just depressed, they also could benefit from those mood stabilizer drugs. Does that make sense? Do you see what I'm saying with this? And so and again, this is not easy stuff, you guys. This is not easy. You have an enormous responsibility to know and understand this. Because, I mean, gang, depression, both organic, functional, and this array here, is a major part of the people you're going to be working with. Your drug use clients, the alcohol clients, and things like that. A bunch of your clients are probably, one way or another, treating, self-medicating for some of this stuff. That could be their major reason for at least starting, if not still using, their drugs. Does that make sense? Those had a woman. And very often, a person with it will know. They'll get an aura. They'll know a day or two before they go up. And for most patients, I mean, that's cool. You know what? Going up is a hell of a lot better than the depths of this misery down here. And for most, once they get up and then they go crazy and they're doing all this nutty shit and everything and they're driving everybody crazy and they're getting in trouble and all that kind of a thing, well, that's not so much fun. But I'll tell you what, when you think about that, this is a hell of a lot better, feels a hell than this. You see what I'm saying? So many patients, that's cool, I'm going up. For this one woman, though, she knew how wild she's going to be and the trouble she gets in, and how just what a wreck she makes out of her life again when she does go up. That manic. And so for her, when she knew that she was going to start to go up, that wasn't a good thing. That was a terrifying thing. And then what would she do? She would start to drink copious amounts of alcohol, as much as she could get in her without killing herself. And what was she trying to do? In other words, alcohol is a depressant. Keep it down so she doesn't go up like that. The only problem is alcohol works on an entirely different system. And so alcohol had nothing to do with her going up, and certainly wasn't going to prevent it. So what does she end up being then is what? A very intoxicated manic person. You see what I'm saying with this? And then we have dysthymia and cyclothymia. What is dysthymia? Another name for dysthymia is kind of depressed. This is the individual, dysthymia. They're just it's like they're always at the doorstep of normal. They just can't quite cross the threshold and go in. Does that make sense? They're just, dysthymia. It's not that they have a major depression, this person, it's just that it's like they can ring the doorbell of normal, but they just can't take that last step in to normal. Does that make sense? They're 30, right there on the edge all the time. And yeah, again, kind of like this. You see what I'm saying? Dysthymia. Does that person need antidepressant meds? Probably not. And when you give that person antidepressant meds, what are you giving that person? Powerful, again, psychoactive drugs that they don't need. You see what I'm saying with that? Watch out for that label maker. How you describe this stuff. And then we have cyclothymia. What is that? Well, dysthymia is kind of depressed. Cyclothymia is kind of bipolarish, where they're like this. Again, does that person necessarily need mood stabilizer medicines? Probably not. And once again, when you give those medicines to that person, what are you giving them? Powerful, psychoactive drugs. You see what I'm saying with this? Don't forget, guys, the only difference between an illegal street drug and these very popular psychological medicines, what's the only really big difference between the two?
Prescription.
Say it?
Is it prescription?
The law.
Yeah.
The law. People in state capitals throughout the country and people in Washington who probably don't know any more than you do about drugs are making a decision about what becomes a drug and what becomes a medicine. They're all powerful psychoactive substances. Now there is one thing that gets, the one thing that gets a chemical on the bad side of that is if it's too much fun. If it's a fun medicine, then it gets scheduled. You see what I'm saying with that? But basically, these are powerful. And does this person, do they need this person, do they need meds necessarily? Rule out that possible. Could we do something else before those meds? Do you see what I'm saying with that? But this could still be uncomfortable. Could this be reasons for self-medication? Mm-hmm. You know what I'm saying with that? And so, just your ability, once again, this range of what these mood disorders look like. Thoughts, reactions, questions to this? Yes?
Okay, you're talking about the cyclothymia. You said that's kind of bipolar?
Kind of bipolarish.
Okay, so not if you were a therapist or a psychiatrist, and if a person had that, as far as him having kind of bipolar and not full-blown manic, going all over the place anxiety, there's a thing that they prescribe, my wife called a boost bar. Boosterine or something like that. It's an anti. Mm-hmm. It's like an anxiety, but it don't have no narcotic in it.
Right. No, most anxiety meds don't have narcotics.
But mine do. Mine Prazolam.
Well,
That's that narcotic.
no, that's
stuff.
not.
It's something. What is it?
It's a major, again, sedative benzodiazepine.
Benzodiazepine.
It does not have
Right,
narcotics in it.
right.
Don't forget it, because I want to make sure everybody understands this right here. The only thing that's really a narcotic is what?
Something from the opium
It
plant.
comes from the
Right.
opium.
I was
from
going
the
to
top.
say, yeah. But she takes the Boosterine.
Yeah.
And so it's helping with her bipolar, but it doesn't have any side effects.
Okay.
It's a sleeper, relax, calm
If that's
down.
working that way for her, fantastic.
So that's-
She got lucky. She got her rates lined up. That's
Right.
good. If that's working for her that way, that's cool. Good. That's not the way it works for everybody.
You don't need necessarily to give any medicine to someone, even if they're.
No, and again, gang, every one of these are going to be, and of course, the decision's here. Who's going to make that decision ultimately? You're not going to make the medical decision.
Right.
The doctor is.
Right.
But that doctor is going to make that decision based on what?
An assessment of
And guess where most of that assessment comes
History,
from?
the client.
You.
I thought it come from the client.
That doctor spends 15 minutes with that client. They don't know what the hell the history of that client is. No. Where does that doctor, what do they know about that client? What you have written.
Okay.
You see what I'm saying?
Right.
That's why you guys got to know this stuff. So that we don't have somebody like this who's getting treated like this.
Right.
You see? In mental health, that patient, they're lucky they get 15, 20 minutes. If they get a half hour, they have just won the lottery. You see what I'm saying?
Right.
And nobody can know that in a half hour.
Exactly.
The greatest psychiatrists in the world can't know that in a half hour. No, a whole bunch of what they think they know about that patient comes from who? You guys. That's why. You are the eyes and the ears. And again, Dan, this is psychiatrist stuff. We're not gonna, yeah, you are going to be kind of psychiatrists. You see what I'm saying? No, you don't get to call yourself that. But so much of what that doctor thinks they know about that patient comes from you. And what you're saying about that person in that file, and that kind of stuff. This is heady stuff, isn't it? This is a responsibility. You guys, I mean, this whole drug counselor thing's getting more complicated all the time, isn't it? You see what I'm saying with that? This whole thing gets a little bit more complicated all the time. This is so very important. Any other thoughts, reactions, questions? Do you guys hear the responsibility you have here to understand this stuff? And you got to be willing to take that responsibility. And when people don't, other people get screwed up. Does that make sense? I don't want you screwing people up. Cool? That's why you got to be here. That's why you got to understand this stuff. That's why you got to care about this stuff. Don't want to know this for the sake of some stupid score on a quiz or a test. Want to know this because who needs you to know this? Your clients. You see what I'm saying with that stuff? All right. Any thoughts, questions? The mood. The affective disorders. Let's move on to another major area with this then. Another major area with this. The personality. Probably the biggest set of issues you're going to deal with. Yeah, you're going to deal with depression. You're going to deal with psychosis, anxiety, things like that. But probably the biggest area you're going to be seeing and dealing with every day are going to be those things we call the personality disorders. The personality disorders have a lot of problems in terms of diagnosis, in terms of treatment. For one thing, we have a medicine for schizophrenia. Not even close to what it should be, but at least we got something. We got medicine for depression. We got medicine for bipolar. We got medicine for anxiety. There's no medicine for personality disorders. We can't find. It's not like we have a broken body part, a germ, a gene, some neurotransmitter. There it is right there. That's why you have that. personality disorder. You see what I'm saying with that? We don't have that. That we use meds on usually, what kind of meds do we use on personality disorders?
Antidepressants?
Downers, to make that person slow down enough that they can stop doing all this crazy shit. You see what I'm saying? That's kind of like the old days when our most popular drugs in insane asylums were what? Booze and opium. Why? Because insane asylums like tired patients better than not tired patients. What kind of meds do personality disorder people get? Downers. Why? Because if you're too tired to be an asshole, you stop being quite so much of an asshole. You see what I'm saying with that? If you get severe enough, sometimes people even get antipsychotics, neuroleptics with this stuff. None of that has nothing to do with, though, the disorder. What is a personality disorder? Don't forget, number one, personality is a what? Personality is a construct. Personality is a construct. There is no such thing. I can't lop open. I can't bring a brain in here and cut it open and say, everybody come around here. I want you. There it is right there. You see it's just right above the corpus callosum. You see where that, there it is right there, the personality disorder. All we got to do is pull that out, put a new one in there, everything's fixed. No, there's no such thing as a personality, you guys. It's a construct. We constructed that concept as a way to understand and explain to ourselves how to better understand people. Does that make sense? There really are. In schizophrenia, there really is a dopamine. There really are those parts of the brain that are being affected with schizophrenia. With depression, there really is norepinephrine and serotonin and things like that. That we have real things. Personality, it's a construct in the first place. We took something that's not even really there and gave it a whole pile of diseases. You see what I'm saying with that? And we've got to remember that. And we often personify the personality like it is a real live thing. Personality disorder. How about this? Let's take a look at that for a minute, right there. A personality disorder. Personality disorder. Inflexible, long-standing, maladaptive personality traits that result in significant functional. These are functional disorders, you guys. You're not born with a quote-unquote personality disorder. This is, you acquire this, you learn this. You see what I'm saying? Result in significant functional impairment and or subjective distress. That kind of a situation right there. Does that make sense?
If it's a learned behavior or how does medicine even help that?
Because, well, like I said, we don't have a medicine for personality disorder. What we do is, if you're acting, personality disorder results in some pretty maladaptive behaviors.
Right.
Nutty, crazy.
So we're treating symptoms.
What you're doing is you're making a person tired enough they stop being quite as much of an asshole.
Gotcha.
Does that make sense?
Yeah.
That's what it is. If they get wild enough, sometimes they even get neuroleptics, those antipsychotics. What we see with this, one major marker in all of these are strained interpersonal. In other words, these are high maintenance relationships, you guys. These are high maintenance relationships. Strained interpersonal functioning. Very rigid. Very rigid ways of seeing and dealing with life, people, stuff, problems. This is the way it is, and nothing's going to change that for that person. You see what I'm saying? Now remember, you guys, remember, this is a functional thing. This stuff was learned in. And just like the hedonic calculus for drugs and alcohol, how did that go? Think about it for a minute. The hedonic calculus for drugs and alcohol. How did that work? What did we say? Everybody with me for a second. I know you
Thank you, Senator.
We got the big old fat plus. Drugs are drugs because they work.
Mm-hmm.
Yes, we're not talking about toenail fungus medicine here. They work. That positive reinforcement. You take a drug, it affects that pleasure center and other things, and it works, and that's nice. But the only problem was what with this? Boy, I don't even have to do this anymore, do I? This is so ingrained, isn't it? And what is it though? The problems start to add up pretty fast. And what did we say? At some point, it's just common sense. It's costing more than it's worth. People don't ruin their lives for the feel good of it. That whole thing. But it looks like it. They're ruining their life for the fun of it, for the feel good of it. That's crazy, nuts, out of control, insane. However, that's if this were the end of the story. Maybe that would be true. But then we have, what was this up here?
1, 2, 3, 4.
What goes away? All that stuff, that kind of a thing. And no, gang, we don't. Normal humans, we don't ruin our life for the fun of it. But we will pay a very, very, very high price for negative reinforcement, making that bad shit go away. Does that make sense? I'm not going to jump out of that airplane for the fun of it, but I'll tell you what, they tell me it's going down, get the fuck out of the way, I'm first to the door. You see what I'm saying? Not for the fun of it, but for the negative reinforcement, because when I jump out of that airplane now, what am I making go away? The airplane crash. You see what I'm saying? I will do things for negative reinforcement I would never even consider for positive reinforcement. You remember this whole thing. We talked about this with the Adonic calculus, with learning theory and everything else. Why am I talking about this now? Because it's the same thing with this. These personality disorders on the surface. Why would you want to be this way? Why? Look at it, nobody likes you. You're on your 4th marriage. You're on your 12th job. You can't this, you can't that. You see, you know what I'm saying? Everybody, you know what they call you behind your back? The fucking asshole. That's what you know what I'm saying? That kind of a thing like that. Why would you want to be like this? Why do you do? And look at what this is costing you. All this crazy shit you do all the time and everything else. And gang, this person, they're doing it. And the cost for what? Well, because they get to win an argument. Oh, okay, well, that feels good. Well, because they get, you see what I'm saying? They get to look like a big shot or something. Oh, that feels good. But gang, the cost becomes more and more and more and more. And at some point, once again, it's not worth it to be doing these personality disorder things. But they keep doing it. Just like with addiction, they keep doing it. You see what I'm saying? Why? Because they're getting something over here also. And these personality disorders, these very rigid ways. And again, boy, you ain't gonna get that. You ain't gonna get that. And what is that? What are they getting? This is that person's way to feel safe in what feels like a very unsafe place in life. Does that make sense? And again, when we look at these different kinds, we're going to see that they're always going to be wrapped around feeling safe. They're making all that bad stuff that scare them so much go away. Does that make sense? By what? Acting in a way that feels like they're protecting themselves from the stuff that is scaring them. Yeah, have you noticed something all the way from, it seems like just about everything we talk about, even this, remember the McDonald's baby brain and everything? Do you ever notice that everything seems to be wrapped around protecting, feeling safe? You ever notice that? 95% of psychology is right here, right there. That kind of thing. And with these personality disorders, that's what it is. On the surface, why? Look at why would they be doing that? Why would they be acting that way? What an asshole you are. Why? And everything else. And it's kind of like, it's kind of like with addiction. Yeah, I got to stop drinking so much. Yeah, I got to stop using that crack cocaine. Yeah, I got to stop using so many OxyContin pills. But they don't. And it's the same thing with these personality disorders. Yeah, I got to stop reacting that way. Yeah, I got to stop treating people that way. But they don't. Why? Because what they're getting for it is still worth more than what they paid for it. Does that make sense? These personality disorders. It's very rigid. And then this last one. This rule is broken all the time. You are not supposed to. You are not supposed to. They're trying to sneak it down to 16, and I strongly disagree with that. You are not supposed to diagnose a person with a personality disorder until they're 18 years old. Why would that be? Why would that be? Anybody tell me, why would that be? Yes.
Because at 16, you're still developing.
Gang, adolescence is a special place of mental illness in and of itself in the first place. That brain, loaded with dopamine, not near enough serotonin to help regulate that. Every day is a major crisis. You ruined my life, Dad. Oh, she doesn't like me after all. Remember this? Do you like me or not? Say yes or. And oh, she doesn't like me. My life is ruined, and all that kind of shit. All that stuff, you guys. Yeah, being 16, being 15, being 14 is a special kind of mental illness all by itself in the first place. You can't be. These kids, they're histrionic reactors and everything else. You can't be diagnosing somebody. I mean, state trait. Adolescence is one ongoing, one after another state of this and state of that, isn't it? And we talked about that when we talked about that whole thing with the process to the product. The whole high school story and all that stuff. All that kind of. Gang, you cannot, don't you dare, I will hunt you down. Don't you be diagnosing people. Don't even be talking about personality disorder. They're trying to do that. They're trying to do that. And you'll see 14-year-old, 15-year-old kids, and they got a personality disorder diagnosis on their file now. Not supposed to do that. Do not do that. And if you see one, don't you pay attention to that. You hear what I'm saying? Jan is a 16-year-old. Jan has histrionic personality. Every 16-year-old kid in this country is histrionic. For Christ's sake. You see what I'm saying with that stuff? Don't you do that. Don't you do that. And then we have problems. We have some problems here. Don't forget state versus trait. And then, well, one thing, difficulties with diagnosis. One thing is we all can look pretty nuts under the right circumstances. Like I told you, the day my dad died, they could attack me with about 5 or 6 personality disorders. Hell, I was probably telling everybody within 6 feet of me to go fuck themselves. You know what I'm saying? And I was angrier than hell.
It says wit, yeah.
Most people exhibit under certain conditions. We all have. I mean, don't forget, guys, and when we look at these symptoms and stuff, you know what's interesting? You know what's kind of funny when we go through these symptoms? I want to see looks on people's faces. Oh, shit, I do that. Oh, shit, maybe I got that. No, gang, this is a matter of extremes. You see what I'm saying? A matter of extremes and a matter of, again, is this state, this temporary state of affairs, or is this ongoing? Does that make sense? So you gotta be careful. Hey gang, is hangover a state of affairs? Is withdrawal syndrome a state of affairs? Is first day in the drug center and having to confront this stuff finally a state of affairs? Is this person going to act pretty nuts in all kinds of ways and everything else, like a real asshole? Does that mean they got a disease? A person? No, it does not. It does not. Now, if you see them 6 weeks later and they're still acting that way, well, that's different. You see what I'm saying with that? But this idea, another problem. Symptom confusion with other disorders and substance use disorders. Substance use. Just the right drug or combination of drugs in the right brain can make a person act pretty nutty in certain ways, can't it? And sometimes even paradoxical. I mean, you know, take alcohol, for example. One person drinks alcohol and they're a disgusting, hugging lover. Oh, I love you, I love you. The next person, they drink alcohol and they're an aggressive asshole. The next part, you see what I'm saying with that? And some of those kind of, so you never know. Other disorders, depression, anxiety. How about cyclothymia? Again, bipolar 1's going to, well, this isn't, we see what this is. Cyclothymia. And that person, they're always on edge a little bit. And you know what? And they probably are a little bit more reactive. They're probably a little bit more this and a little bit more. Is that, you see what I'm saying with that? And so there's confusion here. And be careful with that. Don't give that person a disorder they don't need to have, but don't not identify what needs to be identified.